Good evening, everybody. What's that? Yeah. Good evening, everyone. Thanks for coming. I'm Steve Christensen with the American College of Healthcare Executives, the Minnesota chapter. First of all, I'd like to thank actually our panelists for coming today. We've got a wonderful panel. We've got a lot of content tonight for our presentation. I'd like to thank Dan McLaughlin and the University of St. Thomas for their partnership in our speaker series as well. And with that, I'm actually going to just turn it over to Dan to introduce our speakers and take it away.
Thanks, Steve. Well, welcome to the University of St. Thomas, Opus College of Business, and thanks for everybody. It's nice to see a lot of friends out in the audience. That's great. I'm sure we'll have people drifting in, so apologize about that, but everybody knows how work goes, so I'm sure we'll have a few more. But I'm excited about this event tonight because I started off my career as an electrical engineer inside the healthcare system, and actually was an IT guy, and I used to say I built doodads for doctors at the University of Minnesota. So I'm pretty excited about seeing the very cool technologies that are out there right now from our panelists tonight. And so without further ado, let's get going here. And our first panelist is Susan Klein. She's the administrator of the Department of Pediatric and Adolescent Medicine and Mayo Clinic Children's Center at Mayo Clinic. Welcome.
Oh, I really don't need applause, so don't worry about that. We'll see afterwards if you applause for me afterwards.
I apologize. I forgot to make a comment.
Yeah.
We have cards dispersed throughout the area for questions. So as you have questions, please feel free to put them on the card, and then we'll pick them up at the end and use those for part of our panel discussion.
Just so our panelists know that it's down there too if you want to use that. So either way.
Okay, sounds great. Thanks. So just to give a quick background, I don't know how many of you are familiar with Mayo Clinic, so I just wanted to give you a little brief background and overview of Mayo Clinic and then also the Mayo Clinic Children's Center. So Mayo Clinic, you'll notice from the pictures, you can see the brothers, Mayo, Will, and Charlie. So it's the first and largest integrated not-for-profit group. It's spread throughout 3 to 5 different states, so 3 major ones, Arizona, Florida, Rochester, the upper Midwest with Iowa and Wisconsin. So really spread throughout approximately about 60,000 employees, 3,000 to 4,000 of these are physicians, so MDs, DOs, and then we also have researchers and scientists that are either NIH-funded researchers or they're clinicians engaged in research. So they do patient care, plus they also have NIH grants as well as other extramural funding. So see over 1 million unique patients every year. This was about from 2012, and so it's a little over, I think it's about 1.2. So that's unique, and then on average, there's usually about 3 to 4 encounters per each of these unique patients. So Mayo Clinic Children's Center, if you take the Mayo Clinic as a whole, Mayo Clinic Children's Center is the Mayo Clinic for kids version, so less than 18. So we've got approximately 200 pediatric specialty physicians, scientists, and researchers. We've got over 70 subspecialty practices and integrated clinics and programs, and this ranges from like pediatric cardiology, pediatric nephrology, all the different various pediatric transplant, solid tumor, as well as BMT, et cetera. It's primarily based in Rochester, Minnesota. However, there are pediatric subspecialty services and primary care services in Arizona and Florida. It's a children's hospital within a hospital, so very unique to my colleagues here on the panel. We're embedded within the adult-based integrated system. But yet we have a full service range, just like any freestanding children's hospital, a transport team. We were one of the first level 1 pediatric trauma centers, NICU, PICU, the full gamut. And we're also ranked in all the U.S. News and World Report Best Children's Hospital Specialties, one of the only children's hospitals in the state of Minnesota and across the region, Iowa, Wisconsin, and the Dakotas, that were ranked in all 10 specialties. So very similar to our counterparts in the adult, who is ranked in the best hospitals for the adult specialties as well. So why we're a little bit unique, and why I like to kind of say is a differentiator between us and a lot of the different children's organizations, is because of that parallel within the adult counterpart as well as the pediatric. And I think that's taken into some consideration with how you leverage technology. And so I'll be focusing my slides primarily on systems as well as continuum of care. So from age transitions, not necessarily primary care to subspecialty or subspecialty to subspecialty, but more so the age continuum. So hopefully it does flow a little bit like this. You get to be a baby, and then you get to a toddler, and then a tween, and then a young adult, as well as an adult, and then hopefully a parent who then has a child or has a grandchild, and it kicks back into the system. And so for our children's center, it's a true integrated care model. Mayo Clinic is pretty renowned on its team-based integrated system. It's an integrated group practice. So about 100 years ago, Dr. Plummer was one of the first who thought of, we should have an integrated medical record. So instead of everybody having their own papers, why don't we conjoin and have one paper record? And that was a huge technology advancement for the medicine world, so that patients and physicians could work together as a team to know how everything interacts and integrates with each other itself. And what we're about at the Children's Center is bringing that right expertise at the right time for a patient at any stage of their life. So how we as Mayo Clinic can meet the patient, i.e. the children in this situation, meet them where they are, as opposed to trying to put the children into the system that, as we all know, is very complex and crazy at times and not always conducive to the child as well as the parent. And so this is where we shine in regards to if there's a baby that has a special rare condition or disease, and necessarily our pediatric subspecialists have never seen it before because it's so rare, but yet it's pretty much an anomaly that usually occurs later on in life with the adults. We capitalize and utilize our adult colleagues as much as possible and leverage them to gain their knowledge and experience to help us with these children and work together as a, not necessarily an age-based team of adult versus pediatrics, but a true care team. So with that, some of the technology I had discussed with the facilitators and the organizers of this conference were just a couple of things that might not be new, and they're pretty much established throughout the institution, specifically in a lot of children's hospitals and organizations, but is e-health. So how we term it as e-health within Mayo Clinic and the Children's Center itself is bringing the expertise of Mayo Clinic medical specialists to the provider, whether it's a Mayo provider or to any provider across the U.S. or across the world, or a patient and family without the need for additional appointments or travel. Mayo is pushing really hard to make sure that we can meet the patient's needs, which means not just the clinical needs, but all the other things that come along with it, all the needs that they have in their daily life, which is what they're putting on hold when they're coming to get their health address and healthcare concerns resolved. Another aspect I'll be highlighting is our Ask Mayo Expert tool, which again is a very similar component we're talking about within an integrated system. How do you share all that knowledge? Because that's probably one of the hardest things is how do you share that knowledge at the point of contact with the care or at a relevant, meaningful time when you're taking care of the patient, or as a provider is trying to formulate with their care team what to do for this child in regards to diagnosis or treatment. And so our Ask Mayo Expert tool is a web-based information system that quickly connects, which is highlighted in red because as you all know, if you work with physicians, they don't want it yesterday or an hour ago or 2 minutes ago. They wanted it right then and there when they're talking to the patient. And as a mother, I would want to make sure I get that timely information as well. With that expert clinical information on any really topic or medical condition at any hour of the day or night. So with the e-health, the interactions with expertise regardless of time and location, just highlighting a couple of things. Secure messaging, a lot of people are doing it because it's part of meaningful use, but a lot have been emphasized for Mayo Clinic is secure messaging and making sure with all the nuances with minors, emancipated minors, and the parents wanting to get the information, how do we make that fluid so that parents, guardians, as well as the teens or the children have access to secure message their provider at any time and making sure that they have the right information at the tip of their hands. More so, what I wanted to highlight and give examples on were the e-consults and the video consults and visits. E-consults, provider, what we have established within our system is that there's tons of subspecialists everywhere, but there's always that subspecialist that has a niche, and they often are needed just to answer a quick question. So what we've done within our system is that any provider and institution can order an e-consult, and they'll get a turnaround time at least within 48 hours to resolve a question or resolve a care plan a module for the patient and the family if needed without the patient having come in to see that provider, which is really convenient because instead of having an itinerary at Mayo, you can come in with this undifferentiated, undiagnosed condition, which would typically take you, over a span of 8 months. You can come to Mayo over a 3 to 5 day period and see all these providers to get you that diagnosis and care plan at the end of the day. But do you need to see all those people? You probably don't. And Mayo's pushing very hard to make sure we look at the cost of care for our patients because as we know, healthcare is not affordable. And what can we do as good citizens for our patients to really look at this and take a hard look of how can we redesign our care, even if it's us not gaining that huge revenue at the end of the day, but how can we make sure we can get this so we can take care of these patients and children, and then in turn not have to see them so frequently, because we're preventing a lot of those issues that often recur later on. So video consults and video visits, provider to provider, and then provider to patients. I'm lucky enough to have some of my colleagues here, Keon Jones and Sheree Dean, who work on a lot of these projects. And one of the ones for provider to provider is a simple one that I think some different hospitals are looking at, specifically with subspecialists like neonatology, working with those regional communities and birthing centers that don't have the expertise when there's low birth weight deliveries. And there's a lot of issues with neonatal resuscitation for like a 26-weeker, and the primary care provider doesn't know what to do. Do I transport the baby? Do I put in a PICC line? What do I need to do here? And needing that support. And so we've been using video technology to have we called it an e-delivery room concept for a neonatologist to be there, either take the phone call and see how we could help physically video manage, as well as create a support system for any line placements, resuscitating of the baby, or any other acute issue that the primary care provider doesn't feel comfortable with. And after we did a pilot, it's actually shown a lot of significant benefit to outcomes, but also reduction in unnecessary transports. Because sometimes all it needs to happen is a neonatologist to help stabilize a baby, and also to remind them maybe that the gestational age was incorrect, especially when we see a lot of moms still not getting a lot of prenatal care, and helping them understand that here, we'll stabilize the baby, you know what, you can manage this baby, we'll check in with you later, and you don't have to transport that child to Rochester or to the cities or to some other facility. And then provider to patient, as we know, if you have kids, and I'm sure a majority of you do, or people that have kids or know people that have kids, it's very hard to bring your child to a healthcare facility or a hospital. And you can never keep a 3-year-old's attention really at bay for probably more than, at least in my situation, like 2 minutes, unless there's like dum-dums or stickers or something. And so how can we really make sure, as a provider and a care team group, how can we reach out to our families to say, do you really need to come here? So if we figure out what you need, can we just wrap up those visits? Can we do those return follow-up visits? Regardless if we're going to get that billable revenue, how can we help it so we can help you meet your needs? It's a quick wrap up, and then you can just communicate to us electronically through the portal or secure messaging. And so we're doing that quite often, especially for some of our subspecialists. For the pediatric groups, there are some subspecialties that are very rare. So, developmental behavioral pediatricians are pretty rare across just the graduation of fellowship programs. There's not a lot of them, but there's a lot of need for autism and neurodevelopmental delay. So how do we get that resource to the parents who greatly need it, but don't necessarily need to come to an environment and a facility that most times would upset the child, because it's not a familiar place. And so how can we actually change that experience? And I'll leave some of the human-centered design pieces to my colleague from United Health, because I know he'll be speaking on it. But that is a key thing that Mayo Clinic with our Center for Innovation has done, really focusing on patient human-centered design. So the last one is the Ask Mayo Expert, which is provider-to-provider application. Again, I mentioned about how it's a big knowledge-sharing tool that anybody, regardless if you know the person, so 50,000 employees, over 4,000 providers, they don't know all each other. I mean, they know maybe like the couple people in the offices next to them, but it's very hard to know all the people and know everything that know, and try to put all that brain power and collective knowledge into one repository. So this tool was created to be at a fingertip, so they could do a search like a Google. It's powered by Google, so they could type in certain words and it would pop up. It would have FAQs as well as resources and expert lists. And then also care process models, which is literally like a decision tree that helps them at time of patient care, that they can click through and kind of figure out what they need to do. So a great example would be one of our examples of a long QT syndrome for a child. With ECG monitoring, they can tell if there's a patient that's at risk and potentially has a higher risk of death. And so if a patient with this ECG monitor might have a blip within the ECG that goes out of range, it'll warn this in our EMR, it'll warn the kind of provider and do an alert, and linked to that is the Ask Mayo Expert guideline for this patient might have long QT syndrome. Click here. This is what you'll need to do and adjust your care plan. And so that's really beneficial for our patients that don't see long QT. So I think it was like 52,000 patients, only about 2% of them actually would have maybe leaning towards long QT, and then out of that, about 460 people had a higher risk of death. And so it doesn't necessarily mean that they have long QT, but just the higher chances. So how do we make sure that we can provide the best care even if the resources aren't there in the room with you. So in closing, it's the changing of that care continuum and using technology, whether it's just adapting your EMR from paper to some nice GUI and nice software. But adapting and utilizing technology creates the values that we provide to the care of children. We at Mayo Clinic, but also colleagues around the U.S. in the children's hospitals. It advances the care. One is for that preventable harm, which you'll hear from Minneapolis Children's, a huge piece that we can do, because if you can prevent harm, we should, especially for these kids. And even the adults too, but I can tell you, working in pediatrics is probably one of the best assignments as an administrator for Mayo Clinic. And as an administrator, I rotate every 5 to 8 years to different clinical practice areas. And it's very easy to support a group like pediatrics because of passion that the providers have. And then going on the floor, and all you see these kids, all they want to do is get better, plus watch Dora, but they just want to get better, and you can't blame them. And that's remarkable to see, and it's an emotional pull, and it just makes you want to do better for these kids because they deserve it. This is technology at the end of the day is really going to help them to be better, have better outcomes, better safety and service, but also get that expertise to them, their families, and their communities. Because that is one thing that I know that we all are trying hard to do is Mayo Clinic doesn't need to see all the kids in the world. If we did, that would be impossible for us to have been achieved. We have to collaborate better as partners in healthcare to transfer those patients or make sure that those patients that need to be seen within their communities are seen with communities, give our expert resources and tools to them so they can take care of those patients locally, because they know the patients way better than we would during 1 or 2 visits across the year. So that's a great piece and a great kind of reason why to use technology as described in the previous slides. It's also helpful with streamlining care for children from a child to a young adult to adult. And I'll give you a brief example. My 20 minutes is not totally all up. But it's a CF child. So when they were born, had CF, came into Mayo Clinic, left, went back to their primary care provider, didn't see him for about 10 years. He came back into the institution. The technology was there to update what the primary care provider had done, all the subspecialists he had seen, and then contacting all the necessary people, pulling in the resources to knowing kind of at the stage of life, what do we need to do for this child with CF? Is he ready for a lung transplant? Is he not? Bringing in medical genetic experts that weren't available and trying to say, what should we do for the care plan? At the end of the day, the child chose not to do a lung transplant and unfortunately passed away. And it was amazing to see that every provider that touched that child from baby to 21 years old was in the room when he passed away. And the parent said, not necessarily it's Mayo Clinic, but this is the type of care that they want to see from providers and people that are taking care of their kids. Having that information and knowing the child means a lot. And I think that's ultimately a goal that we all want to try to achieve, whether we're at Mayo Clinic or in one of our local community hospitals. To hear those stories is just like, we hit a home run with that one. We weren't able to save that child's life, but we were able to create a great experience and to continue some learnings from our end just by collecting all of the knowledge and sharing it throughout the community. And then sharing knowledge with others in the care for a child regardless of location and role. If you're a Mayo Clinic employee, it's one thing, but if you're not, how can Mayo Clinic provide some expertise, but create a meaningful relationship with you? Because as it says, it takes a village to raise a child. It takes a village to take care of the health of a child as well. And so how can we all work together? And that's really where we're seeing leveraging technology as a huge aspect to improve care for kids. So
Thank you. We got a lot of really cool presentations here tonight, so that's just a start. Our next presenter is Jason Albrecht, who's the manager of Patient Family Interactive Services, University of Minnesota Amplatz Children's Hospital. Jason.
Thank you. All right. Can you guys hear me okay? Okay. This was an exciting conference. I think just the conversations that we had even before getting started were really stimulating, and it's going to be fun to hear some dialogue as we go along. With what I'd like to share with you today, there's a couple different avenues I could go. There's a lot of stories on how we got to where we are with respect to integrating innovation and technology at the point of care with children. But I'll focus more on kind of what we have in place and where it is that we're trying to go into the future with it right now. So in May of 2011, the University of Minnesota Amplatz Children's Hospital built a new freestanding tower. Prior to that, Going back approximately 100 years, it's been a children's hospital within a hospital model as well. Now we're looking at we're doing a mothers and babies and children's service line type approach. So it's 207 beds. It's the 7th floor facility here, but in talking about what's in place and what's in the design there, the story of the build actually precedes any involvement from architects or designers or anything by 3 or 4 years, in that we engage patients and families. And I'll start by telling a story. These are 2 gentlemen who both lost a daughter to cancer at the hospital. And going back about probably 5 years ago now, they both decided to come forward and say part of their coping, part of what they wanted to be able to do was explore what would be the ultimate patient room for the kids and for their families in order to cope with the experience of being in the hospital for a long time or a short time. Particularly, they wanted what kinds of technologies can be in place to help families actually be families and be together and not struggle with the separation. How can we empower children at the bedside? You know, when you get into a children's hospital for a child, all your locus of control is taken away. You're told when to pee, when to poo, when to take this medicine, sit, stand, sleep, exercise, all these kinds of things. So how can we bring healthy, good choices and that kind of empowerment back to children and help that generalize into their care and into their outcomes? So what we did was we took 3 patient rooms, a couple of them were double rooms, and then basically handed those over, in a sense, the project that these 2 dads wanted to undertake. And through that, they were created into 2 single rooms. And for a couple of years, they were a living laboratory. So following a human-centered design kind of a process where essentially, in co-design process, where patients and families were helping us learn along the way what technologies help, what functionalities do we want to try to achieve, what are some of the elements of these rooms that are really going to be part of a plan that will really advance care moving forward. And they landed on things like how can you put control at the fingertips of a child at the bedside and controlling the ambiance of the room, so things like the lighting, the shades, the blinds, what kind of access to the outside world. What about the things that are barriers to families being families in the hospital environment or healthcare environment, like needing to take care of siblings or needing to do work while you're in the hospital? And how can you balance all of those things and then be together and create that kind of a supportive environment for your patients? And so through technologies and through design, a lot of these elements were addressed until we got into the part of actually working with designers and architects and builders and so forth and art consultants. One of the stories I like to tell you just kind of encapsulates or captures a little bit of the patient-centered design part of it is we started with our architects and designers coming forward with a color palette. Now this might be a nice mix of colors to use for hospitals, and they had vibrant and stimulating kinds of things. When our administration and some of our clinical staff looked at that, we toned it down a little bit. And then bringing it into our parent advisory board, the parent advisors brought it down a little bit into more muted colors. So then we began to integrate it into some of the parent programs. So for instance, at the time I was working on the children's ICU and helping with some non-directed support groups for parents. So we brought these color palettes in and set them all up along the wall in the midst of doing this work with the families and asked them what would they prefer for the color schemes in the hospital. So these are parents that hadn't slept all night. Some of them had just gotten a really bad diagnosis. Some were dealing with end of life. Some were achieving or experiencing basically a cure for what they came in for and were excited in that way. So all different mixes of the people that we're trying to serve. And they brought the colors down yet another level, and then we thought we landed on the right thing. But we can't stop there. We've got to bring it to the kids. So we have a kids council that's been in place for a number of years, so siblings and patients that get in. And then also patients that were currently admitted and brought the colors to them, and you guessed it, they brought the colors down another muted level. So that really set the design and the colors for the build of the rest of the facility. And that similar stories with technology. So with technology, one of the things you hear is technology is great when it works, obviously, but the wonderful thing is a lot of the technology that's out right now is attainable, and it does work at the point of care to help with coping with pain, with comfort, empowerment, and connectivity, and things like this. So as we went on through the build of the hospital, these colors and these elements were worked into the design, so when you'd walk in, kids wouldn't feel like they're in the hospital. They would be stepping into what we call a passport to discovery is the theme, and kind of sets the culture of the place. And there's places kids can go and sit a lot with natural light and so forth. So the lighting side of the technology was a part of it. We have interactive features in the lobby. So, just like Ms. Klein was talking about, to keep a 3-year-old occupied, when you're trying to go through the admitting process and so forth, there's great interactive features. So the big circle there is not just a scrolling marquee for major donors. It's a place where kids can walk up to the smaller marquees and take a picture of themselves, and it goes up on the big screen. Or they can get on there and they can send a message to somebody up in the patient room, and it'll pop up on their TV in their room. They can color pictures right there and send it to the big screen. So constant discovery and so forth. And the technology doesn't end there. We also use this as a big screen for tailgating parties whenever the Gophers football and basketball and stuff like that. We got barbecues out front and the game's televised. So it's really a great achievement there with that touch point for technology. Oh, I should say too, Santa actually talked to all the kids in the hospital and the ones that could stream through from the clinic, from his workshop one day over video conferencing, as they all lined up and talked about what they wanted for Christmas, and great stories from that. But technology can really facilitate some amazing interactions. To kind of bring it down a little bit, what I want to focus on now is two things. One is our Adopt a Room program. So how is it that we can take and leverage technologies to really empower children at the point of care? And then also our connectivity one with our patient video conferencing. We really set upon a vision of trying to make it so that no child that's in the hospital will ever have to deal with total separation from family, school, church, community events, and those kinds of things, especially since the children that come to AMPLATS are from around the world, around the region, as well as across the street. So looking into the rooms, in the design process, we focused on having 3 different sections. So there's a family section, a patient section, and a staff section. And so where the point of view right now on this camera, we're standing on what would be the nursing or the medical staff area of the room, where all the equipment and tube access, all that kind of stuff exists. All the technologies and things in the center of the room are focused on for empowering the patient. And then we hope that we never have to step into that back third of the room. And there's things back there, technologies. You can see there's a mom here that's engaged in work at a computer that has a camera and a TV and all those kinds of things worked into it, as well as a telephone. So here's kind of a panoramic from the family section here. So some of the design elements. So if you look at what colors do you paint your rooms? Well, if you put one of these new LED light bars up at the top, if you want this on a scrolling kind of a rainbow color right now, you can make it a pink room, a blue room, because it really picks up the colors and so forth. It can kind of cascade to different colors. There are just other technology too. So this is a view from essentially the patient's pillow, and you can see there's a video conferencing unit mounted underneath that 55-inch screen, which really is a window to their world that they left behind. And they've got a touch panel on the left there, which is utilized for our interactive patient care. So looking at some of the elements that we're really focused on here, so we've got entertainment kinds of things and distraction. You're getting into the ambiance stuff, the lights and the blinds and the colors of the room. But what's really exciting now that we're in the process of really leveraging and figuring out how we can take full advantage of it, delivering health education, music that creates a comforting, healing environment, gaming systems for a distraction. And the biggest thing here is the communication. So you can, the kids can actually say, I'm feeling good today, or please don't disturb, I want to take a nap, or I love my doctor, I like my nurse, that kind of a thing, or go Gophers, we've got that as an option. That'll get projected to a screen outside the room, so anybody coming in, am I going to disturb this child, or whatever, you can say it's my birthday, or those kinds of messages, so kids can have some control over the message that goes out to a person when they first enter. There's also ways that they can interact with their care team and also the healthcare administration directly from their room and get quick response to their needs, video conferencing, email, and all that. So technology to help connect them with their world. Here's a picture of a patient as she's clicking on, this is a touch panel, and this is kind of the brains of the room. It's connected to a whole set of controllers and stuff. And they can access their Get Well network, video conferencing. There's a wall plate on the wall where they can hook up any of their own media. It's got HDMI, USB, and PC video and that kind of a thing. So any content they come in with that they're already used to, their favorite movies, it's on their own Netflix account or their own iTunes or something like that. Plug it right in, goes through the surround sound, puts it up on the big screen. That kind of control. They can control on the bottom of that screen. It has all the lights and the shades and their moods and all those kinds of things that they can impact on there. But one of the really exciting things here is our interactive patient care platform. There's a number of different ones that are out there. There's LodgeNet and things like that. But we have Get Well Network, and it's essentially, just out of curiosity, how many of you guys have heard of Get Well Network before? Okay, so interactive patient care. So if a few of you have. Interactive patient care is really leveraging technology so that you can have a point at which you can channel communication to and from your patients to engage them in education, quality improvement, service recovery, all these kinds of elements. And essentially you purchase from a vendor one of these products, but it's really dependent on what you're going to build with the technology. They don't give you the answers. They give you the tools, and you work it into your own workflow, and you can innovate with it. So here, this is what it looks like. It's essentially like a web page. All these different icons are interactive. So if you look at things at how the movie theater, you'd get movies out of there, and the hospital would give you health movies. The roller coaster, they can access games, and the satellite dish for connectivity and communication with the outside world. Obviously food with the little restaurant looking thing right there, and there's a parent tab. And so here a patient has either a pillow speaker and a keyboard in order to engage with this, and then you can see the Get Well Town up on the big screen there, and here she's choosing the health and safety movies, and you can, if she had a new diagnosis of asthma, she could click that, and then watch a video on that. And the neat thing about that is you can deliver these really high quality 2, 3, 4 minute videos, and then when you go in to do this teaching, it makes a better use of everybody's time because you're coming kind of from a point of more shared mental model in terms of the families have a chance to look and see and feel and hear what it is, like they're getting a new line placed. You can learn about central lines and so forth. So when you do go in there, they have questions ready. They've seen it. They've seen kids interacting with whatever the device is that they're going to have placed on their body. So a really powerful tool in that sense. We use it for pain assessment and management. So when a pain is, we're working on an interface right now with Epic so that when you administer a pain med and chart it there, it starts a clock on Get Well, and at certain intervals it will ping patients to ask them about their pain levels, and if they give anything but good, it'll go right to the nurse, charge nurse, nurse manager for a response on that. And we'll be looking in the future at other kinds of symptom management to deal with, or to work on there as well. More consistent care practices. So when you think about, you can do a much better job of standardizing the education and the messages that you're giving out to people. You have less gaps, less disparity in what one staff person might say to a family in teaching than another one. Communication with caregivers. So things like the Get Well Network has tell us what you need kind of options in there. So if your room is too cold and you mention that, it'll send it right to the facilities person walking around on their pager or something like that, or an ASCOM phone to come in and respond to that. If you have a garbage that needs to be empty, your food was too cold, rather than going through a phone tree of all the people that would have to figure out who to call, it goes directly to that person. But it doesn't stop there. It comes back in an interval, whatever you set, to ask the patient, was this need met? And if they say no, it bumps up to a manager. And then another time interval goes by, it'll bump up to our vice presidents and they'll come in. So it isn't a way of policing it, it's a way of having a better sense of what are the things that are happening. Do we have low staffing and high need, or what's going on? So we can do quality improvements and then also fix things before patients and families go home having experienced something negative. So the service recovery is a really neat thing. And then of course all the on-demand entertainment. Let's see what I've got, about 5 more minutes here, I think. So patient-family connectedness, our vision I talked to you about, not wanting families to have to deal with the separation. Our goal was to set out so that nobody would ever have to be separated, no matter where you were, what hospital room you were in, or if you wanted to connect with somebody from a consult room. Anywhere with an AMPLATS, we have technology to do this. So video conferencing carts is this kind of a little picture that shows the different ways. The adapter rooms has the video conferencing in the middle there. All the patient rooms have a family computer that have an integrated camera in there for using the software. We have loanable units that will go out to schools when kids want to connect with their schools and not be losing time that way, or at least to be able to do some connections with their peers. We are embarking on a new thing with iPads over our NICU, so we'll have connectivity between moms and babies and external family and the dads that are bouncing back and forth. And of course, families can bring in any device that they have and have it work on there. One of the really unique things is we have a V-room concept where with regular Skype or FaceTime or something, you have one device calling into another device, so you open up a door for the capability of somebody hacking in and spying or something like that. We want to try to make that just as not possible as we could here. So we have worked with a company, excuse me, called Video Guidance in Bloomington, Minnesota here, and we have a V-room concept. So from behind the firewall, the patients and the families choose when they want to reach out, and they go into their own private V-room, and then the people that they've given that information to can call in and connect with them there. So their device on their end will never ring or never be pinged by anybody on the outside. It's when they go to a neutral ground, a neutral safe ground. Here's a young man as he's reaching for the video conferencing on the touch panel, entering his private code, and voila, there they are in their private view room. If another person joins them, that's when they'll see the other person in there. Think about how you can reach out to people. I was just fascinated by Ms. Klein's presentation too on the use of the e-health features and so forth. From the patient family side, we're using this so that the parents who can't be there, we have the proverbial dad in North Dakota milking the cows, can't be here in Minneapolis, can be part of the care conferences and so forth in situations like this, and not have that disparity between one parent's coping level and another one's because of the separation and so forth. That could be an external provider, like a home health nurse prior to discharge. It could be a physician, a primary care physician, receiving this information, staying in touch with their parents or their patients that have come to implants. The school connection, we got a grant from Jostens Foundation to explore how to keep kids engaged with their school. This is a young man who finished third grade, I'll go back to that one, finished third grade on our ICU, half of third grade, while he was on a Berlin heart machine, and then started and did the first half of fourth grade on the ICU. And here he's about ready to give a presentation to his classmates after doing math. And when he got a heart, he was able to come up into our main units and still engage with his classroom. So really fun thing here, I'll share this moment with you.
The really good news, Talidre, what's the really big news that you got last week?
Got a heart?
His physician is on vacation in Puerto Rico, and she's part of this conversation.
The next
She got
really
to tell
good
this
thing
class.
about that means what for you, Talidre?
I get to go home pretty soon.
Oh, what?
It's my brother's birthday.
So these are some of the moments that you can capture with technology like that. I mean, just the kids live into this, the families live into this, especially when you use an empathic design strategy where you just kind of put it out there and let people run with it and see where it goes, and then that's what you support. So with this, I mean, families are doing daily tuck-ins, and the off-site parents being engaged in rounding, people attending school, community fundraisers, blessing services, all that kind of stuff before transplant. So technology can do some really amazing things at the point of care now. So that's
Thank you very much. Let me remind folks that if you have questions, please write them down on cards, and we'll get to discussion. All our panelists are doing excellent on time. I want to congratulate everybody. So our next presenter is Sarah Giga, did I have it right? Who is the Clinical Application Integration Manager at Children's Hospitals and Clinics of Minnesota. Sarah.
Thank you. So just a little bit of information about us, since we are all children's hospitals and all have children's in our name. We all need to do a little better job naming. But we are an independent children's facility, so we have two primary inpatient facilities, one in Minneapolis, one in St. Paul. We have about 18 primary care clinics spread throughout the Twin Cities, and about that many specialty clinics as well as rehab centers across the Twin Cities.
Put it down a little lower. There you go. Hey, try that.
So we have about 4,200 employees, 1,700 professional staff, and latest pictures of our remodeling. So we've been doing a lot of construction over the past year or two, and are pretty proud of some of those new designs. So we've been using the HIMSS analytics model for quite a while to measure kind of where we are in terms of EMR adoption. Where we think we are, especially with the project that we'll talk about today, which is really our closed loop medication system, is around that stage 5. We're certainly dabbling in stage 6 and 7, and probably by the end of 2014 we'll be there on an inpatient and an outpatient perspective. So one of the focuses that we've really had for the last 5 or 6 years is around reducing adverse drug events. And we've had a goal, a lean value system that has had a goal of reducing medication errors by 10% each year. And certainly there is plenty of data around the country supporting the concerns around medication safety. So these are just a couple of different research papers that we pulled information out that you can get an idea of the breadth and the scope of medication issues and errors. So 1.9 million ADEs per year, 180,000 patients die from ADEs annually. So this has really been a focus for us, and a specific area of focus for us has really been around IV medication infusion. So we have over 60% of our beds are critical care beds. So we have a significant amount of our medications that are distributed via IV, and we also know that medications given via IV get to the patient much quicker and are generally more dangerous. So this has been a focus for us for the last couple of years. We started implementing smart pumps, and what we'll talk about today is some of the technology that we've implemented to integrate our smart pumps with our EMR. So we made the decision about a year and a half ago to do a development partnership between our EMR and our smart pump vendor. We made the decision primarily because we wanted to go down the standard BCMA path, but then bring it up a notch, go down to that next level. We knew at the time we had pretty good relationships with both of our vendor partners. Both of them were ready to do it independently, but couldn't find really someone that was willing to take on that additional work. We thought it was a good choice for us, and it really gave us an opportunity to really represent pediatric hospitals throughout the nation. So we tried to do a good job during the project of making sure that we weren't representing just Children's of Minnesota, but we would reach out to our colleagues at other children's hospitals and say, hey, this is what we're thinking about doing. Does this make sense? Is this how you do it? So that hopefully the end product that we were able to deliver applies not just to us, but to our other colleagues. There was definitely, I think we all agreed between us and our two vendor partners, some significant work effort around our pediatric population. I think we all agreed that if we could get it to work in a peds ICU, they could probably take it to any adult facility and it would work just fine. We found a couple of things during the development process. A big one for us was around the percentage of our orders that are ordered as weight-based doses, and that is something that they just don't see in the adult world, and really the software was not developed to handle those situations. The things that we found post-implementation, because every unit was unique, in our NICU was just dealing with the small weights and volumes of those babies, so making sure that we had enough level of precision of the data coming back. Didn't realize how important that would be until we got to that NICU. So this is what our ideal workflow would look like. So we started with just typical BCMA, which I'm sure a lot of other hospitals have done. Let's see if we can get the pointer to work. So it starts with just scanning the armband, making sure in the EMR that you have the correct patient. You scan the medication, verify in the EMR that you've got the correct med, the correct time, the correct dose, the correct route. All of those you should get an alert on if it's not correct. You document that medication administration within the EMR. What's unique about our implementation is really what's in this red box over here. So for any medication that's delivered on the smart pump, we go an extra step. So after the nurse has documented the medication within the EMR, they are using that scanner to scan the smart pump. And when they scan the smart pump, the order goes from the EMR and wirelessly is transmitted to the smart pump. It pre-programs the smart pump. The nurse validates that the information is correct on the pump. They press start. The pump starts to infuse. And then in our critical care units, the smart pumps are actually sending data back into the EMR. So it will send back volumes, it will send back rates, it'll send back rate changes. So as the nurse titrates at the pump and makes adjustments to the rate, those rate changes feed back into the EMR immediately. And that step 8 is really unique for us in the critical care units only. Now in terms of implementation, we have rolled this out. We started in 2012. Our first implementation was in our PICU in Minneapolis in March of 2012, and we've now completed rollout in all 381 of our inpatient beds, and have started to move out into some of the other areas, so our ED, our surgeries in pre-op, post-op, and PACU, and short stay units as well. So we have almost completed our full implementation of rolling this out across our facilities. So of course, what everyone wants to know is, so great, you implemented some cool new technology. We're the first pediatric site to really do this, but is there value? And so the question is always, are you providing safer care? So some of the things that we've looked at a high level, and in a lot of cases in a lot of detail in terms of getting through all of the data, is we've certainly have found evidence in several different areas that we've seen significant improvements in terms of safety. One of the things that we've looked at is our safety learning report. So we have a self-reporting system where staff can log safety concerns into a system. We have seen a significant reduction in medication administration events, around a 37% decrease in those medication administration safety learning reports. since we implemented this project. We also have plenty of sort of ad hoc nurse reports of benefits. A lot of that is around the BCMA pieces, the good catches of the wrong dose, those sorts of things. We've also seen an increase in our patient family satisfaction surveys. So one of the questions that we ask our families is, are staff checking the staff checking your child's ID band before they administer the medication? And we'll look at that data a little bit to show we can actually tell you where our go lives are based on that data. The other thing that we really wanted to measure was around that smart pump integration. So are we utilizing our smart pumps better? And we'll take a look at that, but we've definitely seen a huge increase in the percentage of infusions that are running within those safety guardrail parameters on the pump. So we started just by looking at how well are the nurses utilizing the technology. I think one of our concerns has always been it's generally easy to implement technology. The question is it easy to sustain it? So do people continue to use it? Is it easy to work within their workflow? So our goal has always been, from a BCMA perspective, that we want the nurses to be scanning the patients and the medications at a 90% rate or better. And we're pretty happy with where we're at. This is data that we post on the units on a monthly basis to show them what their unit level compliance is, as well as we post another version of this that shows at the individual nurse level what their compliance levels are in terms of medication and patient ID scanning. And this is the family feedback survey. So this is one of the questions that we ask is how often are they checking the ID bands on your kid before they administer a medication. And we can tell that this is when our first major go live was. So it's good to show that we have some good factual data, and the families really noticed the improvements. They noticed that we're checking those medications, checking the armbands consistently. We also looked, just from a BCMA perspective, what are the things that the data can now tell us? So we've had another lean initiative going on for years around floor stock medication. So we've known for years that we've had a problem with nurses going into the stock room and grabbing the wrong bag of fluids off the shelf because they look alike. They're just bags of fluid. So we've had many lean events where they've done, the tape on the floor, the different color codes, all those things. But still, we continue to have problems with that. So the real benefit to us around this technology and these solutions is that now we actually have data that will tell us how often did the nurse try and hang the wrong bag of fluids based on what order was in the system versus what they scanned. So we've been able to use some of this data to go back and find the units that are struggling and make some of those improvements. We also have noticed things around changes of orders in the system. So we talked about this earlier a little bit, that the physician places the order, it needs to go to pharmacy for verification, for dispensing, it gets to the floor, it may be several hours before the nurse actually administers it. Well, a lot of things can happen in the system between when the order was originally placed versus when the nurse administers the medication. So with this technology, we've certainly been able to alert the nurse to when those orders have changed. So we're tracking, so how often are the orders canceled, are they discontinued, or have they been modified between when they were placed versus when they're actually administering the medication. And this is probably some of our more exciting information, and this is really around our smart pump implementation. We've had our Alaris smart pumps for about 10 years, and the idea was always that the nurses should have been programming the pumps to be within guardrails or the safety software on the pump. But part of our problem was there was no good way for us to measure that utilization. So we used to do ad hoc surveys or walk-arounds, and people would check the pump, physically check the pump to see if it had been programmed into guardrails, but really no good way for us to measure it. So one of the things that this technology in this project has enabled us to do is measure it. I think that one of the things that has shocked us a little bit is how poor our utilization was prior to implementing the technology. But what's been really exciting is that the technology has been adapted to very well by the nurses, and we've seen almost on average a 50% improvement of guardrails utilization across all of our units. And in some areas it's been drastic, going from a very low percentage of utilization up into the 60-70% 60 to 70% range, which is very exciting for us. So we're very proud to have been able to undertake this development effort. It's been quite a learning experience, I think, for all of us. I'm proud to have been recognized by several different organizations within the state of Minnesota around our safety and quality initiatives and the improvements that we've seen around this project. I think the other thing that's exciting for us is this was definitely our first development initiative, and it was a really positive experience for us overall. So I think it certainly is going to open the doors for us to take on more of these initiatives. We know that there's lots of other opportunities and exciting things, as you guys have certainly shared with us today, that I think we'll be in a better position to take on.
Thank you very much. Our next presentation is from Paul Fiore of the Marketing and New Business Development and CME Manager at Gillette Children's Specialty Healthcare in St. Paul, Minnesota. Paul?
Thank you, Dan. Can everybody hear me? Is it okay? All right. Well, a great forum. Thanks for the University of St. Thomas and the Minnesota chapter of the ACHE for putting this on. I've now got about 10 or 12 new things on my to-do list and to explore list for tomorrow. So the good and bad news of that is that we're creating a lot of great work for ourselves. I wanted to give you a little framework for where we are at Gillette. So geographically, this is our newest building, which is located right off of University Avenue. If you can imagine that the state capitol is right up here a little bit, about 2 blocks. So we're just down University. We are co-located on the Regions Medical Center campus, so the Skyway goes over to Regions. That's where most of our patient care is being done. The reason I bring this photo up is that we're going to talk a lot about rehab therapies, which is for our St. Paul location, located on that second floor. And to give you a little bit of a framework for who we are and what we do, we were the first children's hospital in the nation that was publicly funded for kids with disabilities. That was about 116 years ago. And our patient population tends to be those kids who have physical and functional disabilities. So kids with cerebral palsy, spina bifida, a lot of complex orthopedic issues, craniofacial anomalies like cleft lip and palate, and craniosynostosis. And then we see a lot of kids with brain and spinal cord injuries. So our patient population tends to be with us for a long period of time, and we really see them throughout the continuum of their care. Because of the complexity, we tend to be way at the end of the case mix index scale. So we tend to get the sickest of the sick or the most complex kids, and that really dedicates this model of interdisciplinary care. So kids in our institution tend to see PM&R physicians, orthopedists, neurologists, and they see kind of a spectrum of providers across the course of their care. Geographically, we see kids from every county in Minnesota, 42 states around the country, and about 13 foreign countries. So because we're a niche hospital doing specialty work, we tend to see patients from a pretty broad geographical area. So the organizers tonight asked us to do a number of different things, to really focus on technology and what's happening in our healthcare environments, to look a little bit at advocacy and how advocacy is being delivered or utilized in all of our settings, and then this focus on population health and how can we utilize technology to impact population health. So that's a buzzword now in the community, in the healthcare literature, that is the big, broad population health. I'm going to skinny it down tonight, and we're going to talk population health in relation to kids with disabilities. So I hope that we can provide some good examples for you. So I will fully admit that I think I have therapist envy. I think they have the funnest jobs in the world. And I've really been, impressed with how technology has now been integrated into the rehab environment. So what I'm going to focus on tonight is what's happening with technology and how it's being delivered for patients in 3 different areas. And to be fair to my rehab colleagues, I'm going to pick 1 OT, 1 PT, and 1 speech and language pathology so I don't get into trouble. Our Mayo is a new exoskeleton that's being used for upper extremities. It's being delivered by our occupational therapy colleagues. Locomat is a robotic gait orthosis, typically being delivered by PT. And I'm going to focus on eye gaze, which is something that is pretty unique, and it's being utilized by speech and language pathology with a little bit of overlay of occupational therapy. So just to set this up a little bit, I think technology is really, I'm going to go over here and use the mouse to point. Technology is really what's driving a lot of innovation in rehab, but what my colleagues there tell me is that it has not at all diminished the clinical expertise that's needed to select the right modality for the right patient for the right rehab setting. And so I think actually it has amped up the need for better clinical expertise. And I got to tell you that I see these young graduates coming out of training programs for rehab now. They're brilliant. They are great clinicians. They're really smart. They're really dedicated to advancing care. And this is the generation that's grown up with technology. So they're not afraid of it. They're embracing it. They're looking for new opportunities. And you know, the PT students coming out are now all at a doctoral level. I think OT is going in that direction. So they're really bright clinicians that can utilize this technology in an innovative way. So here's the other new development that I'm going to focus on a little bit is the patient engagement component. So a lot of the new rehab modalities are integrating a virtual reality setting or some kind of a gaming setting so that patients can get some immediate feedback and they're self-directing the games or the avatars in ways that are therapeutically advantageous to them. So we're going to focus on that just a little bit as well. So let's dive into the first one. I'm going to get a really stiff neck doing this.
You can look here too.
Yeah, I know. I'm getting a lot of feedback here, so I'm going to just move this just a little bit. Our Mayo is the upper extremity exoskeleton. It is an arm weight supported system that's really, the key here is it's self-initiated movement by the patient that's repetitive, task-oriented. So again, the settings that the rehab therapist will set on the virtual reality setting or screen are actually what's going to benefit that patient in the rehab setting. You'll see a good example of a couple different virtual reality settings. Again, this can be adjusted to increase speed, repetition, engagement, and it's really kind of a cool interaction. There are assessment programs built into all of the software, so the therapist in an individual setting or longitudinally across settings can really determine how that patient is progressing and can adjust the scenarios to best benefit their rehab. The recommendation here is that this is a pretty intensive course of therapy. So they're recommending that it's 3 times a week for 6 weeks or 2 times a week for 9 weeks, and it's a 60-minute session. Now, the patient I observed twice, after 40 minutes of his first session, he was wiped out. He was working hard. He's a big, strapping kid. You'll see him, but he was wiped out after 40 minutes. The next time I saw him, he got through the session, and he was flying. So it's really interesting to see how this can move kids along. The patient population that we're using this with, lots of kids with hemiplegia, so one side affected more than the other. Oftentimes in our population, that's due to cerebral palsy or stroke. We're using it also with patients who've had traumatic spinal cord injuries or brain injuries or brachial plexus injuries. Just to give you a hint, that's kind of an unfamiliar term. Brachial plexus is a network of nerves that come from the spinal cord, innervate the shoulder, arm, and hand. So these in older kids are oftentimes injured if you've got a sports injury, depression of the shoulder, an extension of the head, or some kind of traumatic accident. You see it in babies too. So big baby, big shoulders, small birth canal, oftentimes they get caught and they'll have brachial plexus injuries. So we're going to show a quick video now, and this is my guy. And you'll see him kind of progress through the session. He's just doing a quick warm-up now. You'll soon see a shot of the setting that he's working within on the computer screen. His hand, so he wants to increase his grip strength and his shoulder strength. So this is just kind of back and forth movement to get him warmed up. He's actually catching all of these little raindrops in the cup, now working a little bit harder. And then really all of the games that he's working on through his session are really focusing on grip strength, and he's a pretty good turkey shooter too. So throughout this therapy session, he went through about 8 or 9 of these scenarios, and the therapist is setting different scenarios, again, trying to work different muscle groups, different movement patterns, and really design that therapy session to best maximize his rehab. And this is a little bit more fine motor skill that he's working on here. So this guy did a great job. He loves the therapy modality. His parents love it. They're just really thrilled to be working with this particular device. So there's an interesting advocacy story here. You know, advocacy comes in lots of different ways, but Kristen, who is the therapist in that particular example, before we had this system, she thought that there was a better way to deliver upper extremity rehab for our patients. So she applied for what we call a clinical specialist project, where you can actually apply, you get accepted, you carve out a little bit of your time, it's funded to the organization, and you do the research. So she went out, researched the literature on what the new modalities were for upper extremity. She researched what technology or devices were out there to enable this, and then she called lots and lots of facilities who were already using this. She submitted her project, her colleagues loved it, she submitted a capital budget request, and it got funded. So here's a therapist who says, hey, there's a better way, I'm gonna do this, I'm gonna make it happen for my patient. So as we've been trying to build in advocacy to these presentations, I think that's just a kind of a unique way to look at it. So our second example is Locomat. This is a robotic gait orthosis. So the difference between our Mayo is all self-directed movements. Locomat is robotic, so it has some movement generated by the robot that can be adjusted. So a child new to therapy who doesn't have much strength, robot's doing a lot of the work. As they progress, the robot's dialed back, and the patient is doing more and more of that work. So here's just an example. I'll point out a few things for you. So weight supported. So oftentimes these patients who are probably post-op or post-brain injury don't have the ability to support their own weight. So here's the weight supported system here. This avatar is actually what they're controlling. So they can program this avatar to do straight ahead movements, to do side to side, obstacle courses, they kick soccer balls. I think there's lots of different things that they can do. The virtual reality component on this device isn't quite as robust as our Mayo. And then there's a treadmill. And here you see the kind of exoskeleton. So again, patient population, pretty similar. Lots of our kids with cerebral palsy have pretty complex orthopedic surgeries throughout their life. And also spasticity is a big deal for kids with CP. So selective dorsal rhizotomy is a way to reduce spasticity, neurosurgical procedure on the spine. But when you take away that spasticity, oftentimes they have to relearn muscle movement and muscle patterns to walk. So this is a good therapeutic intervention right after that. Again, TBI, spinal cord, and spina bifida are patient populations that benefit from this. So here's our gal. She's 7. So she's a pretty tall 7.
Purple pig. Hey, remember what you gotta do? You gotta kick him right in the nose. Give him a big kick.
Okay, so it's a little noisy, the device. Oh, I lost her.
Just hit the space bar.
She's back. All right, press the wrong button. We're really in trouble now. There. Okay, let's go back. We'll get her back again. Okay, so she's working away here, and the therapist is actually working a game where she's telling her to kick that pig as hard as she can. And the interesting thing is she's doing it, and up above here this is a biofeedback monitor. She stops and she comments to the therapist, hey, my left hip is really working hard today. Then she uses her good low post skills, good touch around the net, score. So this is really a cool way to see kids progress. This is the most restrictive device that's used. And after they progress from this, they'll go to less restrictive devices along the way. And again, lots of control here. So controlling weight to put more weight on the legs, controlling the robot to stimulate more movement by the patient, and lots of different games along the way that the patients are participating in. So our last one is really related to augmentative and alternative communication. So this is really defined as all forms of communication except for oral speech. So hand gestures, facial gestures, anything that a patient can do to express their thoughts, their desires, their needs. I work with a colleague who had a brother who had very profound CP, and she helped him write a book by looking at his facial gestures. He could actually spell using his facial gestures. She interpreted every single letter in that book and wrote the book for him, and it's pretty outstanding. So different ways for people to communicate. And the one I really want to focus on here is eye gaze. And this is user-initiated communication with a computer interface. Before we get into that, lots of different ways to communicate, from the very low tech. So this is a switch. You hit the switch, it has one verbal signal. I'm hungry. I'm cold. I want to go outside, turn the lights on. Whatever it is, you can program one. There's also picture books that either the person can point to or they can have a designee point to. The next line up is a punch screen. So you've got a series of commands. Press the button. I'm cold. I want to go outside. Time for school. And then the next is kind of this more higher tech touchscreen device, lots of different programming menus. But the one I really want to focus on is this device. This is eye gaze, and I had a chance to use this. So this is small. You know, it would fit on the table very easily. It will fit on a patient's lap tray. So we've got some colleagues from our assistive technology department here. Easy to mount on a wheelchair, and I'll show you a piece of that device, or show you a wheelchair with the device mounted. But the important thing to think about here is imagine the patient who has low motoric skills, can't move very well or at all, but cognitively is intact, and how frustrating it might be for that patient to interact with their environment and communicate. Eye gaze allows them to do that by actually, you calibrate it to read where your eyes are pointing. This red dot up in the right-hand corner are where my eyes are pointing when I took that particular photo. But talk about access to the world. Okay, this small device, you can spell a message, you can get on your Facebook. You can get on your email, you can Skype, manage your calendar, your Windows applications, you can text, you can phone. Environmental controls. You can control the heat and the light in your own house, you can control doorways. This is the window to the world for patients who have low motor skills but good cognition. And I think that this is really kind of a cool way to look at how we empower people with disabilities. This is just the keyboard touchscreen. Again, your eye gaze will enable you to spell messages. Here's a young boy with his mother, and our assistive technology staff has mounted this device on his wheelchair. All is good, right? All is good. Here's what happens. So here's the process. A very, very detailed evaluation by a speech and language pathologist to try and assess communication skills and abilities of an individual patient and what device might meet their needs. This is no small feat. This is a big deal. After that's done, there's a review of appropriate devices with the family and the patient, and they are, making choices. What's going to work the best? There's oftentimes then this 30-day trial, which is a vendor-initiated loan. So patient gets the device, they go off and they try it at home, and they may come back and say, yep, that's right for me, or no, I'm not sure, let's try something else. So what happens then? The device goes away because they have to lend it to somebody else, and here's where the big advocacy comes in. The therapist and the family submit documentation for purchase to their insurance company. How easy do you think that is? It's amazing in talking with the therapist how often it is a 6-month process to get anything funded, if it gets funded at all. Our adult speech and language pathologist told me that MA funds more of these devices than private insurance, which I almost flipped onto my head. So very tough to get funded, and I'm not trying to throw any stones at insurance companies, because if it's not assessed right and it's not the right device for the patient, guess what happens to it? It's in the closet somewhere in 6 months. So, okay, let's do the right assessment. But again, this is the window to the world for those patients. The other challenge is the last bullet point here, is that for an eye gaze device, it's a long training period. It's 3 months with a therapist. And insurance companies that are funding the device are saying no to that 3-month training period, which is a little bit of a disconnect for me. But that's the state of the art. That's the state of the science. That's what's happening, and we need to figure out how to make it better. At the end of the day, this is what we want to have happen. Just one more quick advocacy example, and part of our challenge tonight was to look at partnerships as well. This is at Target Field last weekend in a partnership with CenturyLink and the Minnesota Twins as part of our Cure Beauty campaign. And we at Gillette like to advocate for kids with disabilities and trying to get the world to look a little bit differently and not feel sorry for kids, but look at them for what they can do and what they can participate in and the challenges and the barriers that they've overcome. So we're trying to move attitudes forward, and Target Field and CenturyLink were gracious enough to do that. They carried it into the stadium. Interestingly enough, this was taken Saturday evening. If you were to go 2 miles directly this way, you would run into TCF Bank Stadium, where Jerry Kill had a seizure on the sideline on Saturday, which I think is a little bit of a different message that was portrayed by one of our columnists in the media about people with disabilities and what they're able to do. So we're out to change attitudes and perceptions and see kids in a different light. And we hope that our media members can take that on as well. So just one last slide. I had the great experience through this presentation to meet a lot of our therapists and talk to them about what they're doing. And again, I think I'm going to be a closet therapist here. But again, very talented people. I just wanted to thank them for their time and expertise. So thank you.
Thanks, Paul. This stuff is so cool, I think I gotta go back and be a hospital administrator again. So, our last presenter is Ben Kell. He's the Senior Director of Strategy and Innovation at United Health Group, responsible for the development and market launch of new innovations for the various healthcare markets served by the company. Ben.
Thank you. That's a mouthful. And happy Talk Like a Pirate Day. That is a real day today. And no, I'm not going to talk like a pirate as much as you'd like to hear me do that. You know, you guys have been sitting a lot, and I am the last guy, and I appreciate your guys' attention. I want you guys to stand up real quick. Introduce yourself if you haven't to your neighbor, and tell them what, in the spirit of kids, what was your favorite toy growing up? Okay, so let's go ahead and share it real quick, stretch a little bit. Favorite toy? All right, let's start wrapping it up. You're cutting into my time. All right, let's wrap it back down. I knew that was a risk. Everyone would much rather talk about toys than hear me speak. But no, appreciate the time and energy. Just so you know, my favorite toy were Legos growing up. Not that you care that much. And it's been a pleasure of mine. I have 3 girls at home, and I'm fortunate enough to have them like Legos as well. However, my Legos that I had as a kid were a lot of medieval castle things with knights and bad guys, and that's how I used to play with them like they should be. Well, my girls play with Legos, but now they play very different. So people get married, they walk down the aisle. It's blasphemy in my eyes, but still happy they play Legos. So again, thank you for your attention tonight. So my name is Ben Keel. I work at United Health Group, and I'm really ecstatic to talk about kids. I think kids is one of the most important aspects of care that we deliver. In fact, kids are 25% of our population today here in the U.S., but I think we can all agree that kids are 100% of our future, right? And when you think about that, the difference that we can make in improving health of our kids is significant. We have a legacy to leave behind, and healthy kids is part of that equation. And if you think back to the last few decades, we've made a lot of progress in the health of kids. A lot of diseases that used to kill kids no longer do. We have immunizations or ways to treat them. We've reduced infant mortality. A lot of good stories are out there about what we've been able to do as a health system. But not all good news is good news. When you think about today that nearly a quarter of our kids have at least one chronic condition, there's work to be done. When you think about just now that standards for preventing obesity are just now being rolled out nationwide. And based on a recent study that we did, we often find that care is still very siloed. It's very expensive, and it's often too late with kids. We still have a lot of work to do today. So again, we have a lot of things to look back positively, but I think we can all agree that there's still a lot of work to be done. So today, what I'd like to do is share with you 2 quick things that I think kind of get in the way when we start thinking about solutions for kids, from my perspective. I want to introduce a methodology called human-centered design that at United we've been using for a couple years now. I know many of the companies here talked about patient-centered design. I know Mayo has been a leader in using human-centered design, but if you've not heard about it, I want to make sure that you guys have an understanding of what that is. And then finally give one example of a project that actually is still in progress where we've applied human-centered design thinking to the pediatric space. So let me first start with one of the first things that I think that gets in the way of us designing good solutions, and that is kids are not little adults, right? with one exception, kid president, right? And if you've not heard kid president's talk, you should go to YouTube tonight when you get home and YouTube him. He's very motivating. So with one exception, kids are not little adults. And kids really differ, I'd say, in four main ways. One is they're obviously developing, right? So kids are still developing, which means that treating them can be difficult, and developing meaningful experiences for them can also be very difficult. The experience I designed for a 5-year-old girl is going to be much different than a 12-year-old boy, and so often we treat them all the same. They're developing, which makes it a challenge. The second way that kids are different than adults is they are dependent upon care from somebody else. They're not alone in the healthcare space, but they rely on other people to make the decisions for them and their care. The third, I'm stretching the D theme here, it's a different epidemiology. So kids have different, diseases present themselves differently, and as kids mature and age, those can change the way they impact the kid, and sometimes they can even go away completely. And then finally, demographics. Where a kid lives has a significant impact on his health, especially when you live in high poverty areas. In fact, there's a lot of study that we've recently done, and it was done at Mayo Transform last week. A lot of research is showing that your zip code has more of an impact on your health than your genetic code. And so thinking about the social factors that impact health is a significant deal as well. And again, kids have no real impact or influence on that. So when we think about how do we develop solutions and treatments for kids, let's all remember that kids are not little adults, okay? The next thing is, who's doing the designing? So who here is doing the designing? Is it kids? And I found this little cartoon that kind of pokes humor at it. But oftentimes, it's adults that are doing the designing, right? And we think as adults we know what kids really like. We know what kids enjoy to do. That isn't always the case. And so unless you have kids designing the experience for you, which I was ecstatic to hear Jason talk about, a kid panel, right? We need to have more kid panels because that's how you really understand at a deep level what a kid's needs are and their perspective, and you can help develop more solutions. And if you can't have kids design solutions for you or with you, you better have people that can get to that level of specificity and understanding, because if you don't, you're likely going to miss the ball, okay? So these are two aspects that I think we often get wrong is, again, we treat kids like adults, and we don't often have the perspective of what really is important to a kid and what needs they may have as we look about giving them treatment or experiences in the healthcare system. So how do we go about really understanding that? And this is where human-centered design kind of comes in. So who here has actually heard of human-centered design? Is that a new concept? Oh, good. I can probably move through this pretty quickly. How many have practiced human-centered design, actually done it? Great. Even more. So where I like to start with this design concept is first to hear your perspective on what is design. What do you think about when you hear the word design? How do you define it? This is where it comes interactive here. Shout it out. What's design to you? Oh, come on. Innovation? Okay. Other thoughts? What is design to you? What words do you think of when you think about design? User-friendly. User-friendly, okay. Solutions. Anticipating, okay. Observation. Creative, okay. You guys are pretty good. Oftentimes what I'll hear from crowds is it's more about how things look. It's making things look cool. That's what people think about design. And I think it makes sense because a lot of it's graphic design based. We all see the car models that Ford or someone else puts out. And so we think about how things look as design. And for just clarification, and many of you know human-centered design, so this won't surprise you, when we talk about design here, it's not about how things look. It's actually how things work for people and kids. That ultimately is the goal. When we design new experiences, we should be thinking about, do they actually work for people and do they add value? So when we talk design, this is the definition that I'd like to kind of level set with you guys on tonight. Now, before I jump into what is human-centered design, because human-centered design by itself is a multi-week, you could go to Stanford D School and study it for a whole semester. So you're going to get the abbreviated version in 5 minutes or less. You all have your green belts in human-centered design by the time you walk out of here. And there's really two key components. I'm going to break it down and keep it simple for you guys. One is understanding. So in order for you to be a good designer, you need to understand who it is that you're designing for, and you need to understand them very well. Let me put it in context for you guys. So think about the last time you bought a gift for somebody, okay? And think about, did you know them very well, or did you not know them very well? And based on your understanding of that person, how confident were you that the gift that you bought that person would actually hit the mark with them, right? And I'm going to guess, I'll take a stretch here, that people that you actually know very well, you're going to be much more confident the gift you bought them is going to add more value, right? Versus the person I don't know very well, I'm just going to guess, probably take the easy way out, buy a gift card. That's what I do. But that's the reality of here. So designing solutions or services is no different. The more that you know your person you're designing for, the better that is. The other tip here is that it often requires you to get out of your own building, right? So we often will sit in a conference room, we'll look at survey data, all that kind of fun stuff to really say that we understand the person. Well, no, that's not the reality. You need to get out of your building and go to where your customers are at. Where are the people that are going to use your services living at? Go into their homes. If you're designing for care providers, go into the clinics, go into the hospitals, go into facilities. You need to get entrenched in their world, and you can't often do that while you sit within the four walls of wherever you're at today. So key to human-centered design is understanding. Sounds easy, but people often have a lot of different types of needs, and it's always hard to talk about, well, which one's the most important one? And to illustrate that, I always like to use this picture here. And again, this is another part of interactive. I didn't warn you before I started. But what does this girl need? And I want you to shout it out again, interactive. No, she doesn't. No, she doesn't. She does not need that. What does she need? She needs a book on the shelf. She needs a ladder. What else does she need? She needs answers, okay. What else? Anything else? Needs to be taller. Okay. We'll stop there. Those are all great needs. In fact, I wouldn't argue with any of them. I think they're all relevant. But I think that points out we all looked at the same picture, but yet we all saw different needs. And if you think about it, if you were to stop and think about how would I actually solve for that need, the solutions would actually be very different. As well as, so think about someone said that she needs a taller ladder. Well, okay, how would you design a solution for that? Well, you might build a taller ladder. Maybe you build one of those things at the warehouse that lifts you up and down. That would be one solution. I also heard someone said she needs an answer, which is, part of what we do in human-centered design is ask 5 whys. It's also used in Lean Six Sigma. But it really, in essence, go back to your 7-year-old and why? Why is she trying to get what is she can't reach a book. Well, why? Well, she needs to reach a book to get some information. Well, why? Why does she need to get some information? To get answers. Well, why does she need to get answers? Well, let's just pretend that she's trying to get her mom and dad's attention because she competes with 4 different kids at home. Each level that you just peeled back there gets deeper and deeper and deeper. And if you stop to think about what solutions you would develop for each of those needs, they'd be drastically different. So ladder versus how would you design a solution to actually make her stand out to her family? Much different, but which ones do you think are much more impactful? The deeper ones, right, which are often hard to get at. So design thinking, really, you need to lean in and not, take the surface level because that's going to be very incremental in nature, but really dig deep to understand truly what's going on with your customer. Now, the second part of design is making. And this, for me, was probably my most uncomfortable part of the process. It was actually prototyping. Prototyping is something that's very, I shouldn't say it's unique, but it's a big part of human-centered design. And this is taking rough prototypes, so very early in the process, and actually putting them out in front of your customers. And we've all been trained, to make things perfect, and I can't take this product out, until it's polished and it looks good. But really, if you do this process, you'll find that drawings and role-playing and acting and just taking Post-it notes to represent an app, a new app idea that you have, those are all things that really make the idea come to life. And the sooner that you can get those things into the customer's hands, the more you're going to learn, right? The more you share, the more you're going to get back, and the sooner that you can do that, the better. It's going to speed up your innovation process, and it's going to de-risk your process. I'll be really critical at United. We're very good, or we have been very good at, asking for $500,000, $1 million for this new idea or this new website or this new app that's going to be awesome, and we'll get it, and we'll spend 6, 12, 18 months developing it, and then we'll stick it out in the market, and it sucks, right? Right? I mean, but what would you rather do? Where would you rather learn that your idea sucks? And it's going to suck no matter what. It's going to suck after $1 million. It's going to suck after 10. But would you rather learn about that up front with maybe 2 months in with maybe, $30,000, or would you rather wait 6, 12, 18 months? Because where do you think there's going to be higher stakes at, right? It's the latter. So a big part of human-centered design is prototyping quick, fast, and very low fidelity. So that's human-centered design in a nutshell. Again, you can go on for hours on this topic, but hopefully that gives you a good sense of what we mean by human-centered design. And when I talk about my example, I'll give you a little bit more context. The last thing I want to leave you with is this picture, which are basically 3 different components that are really important for any new innovation, right? So obviously, a very good innovation needs to be desirable. This has got to be something that people actually want to use or want to experience. It's got to be feasible. I can come up with the best idea, but there's no way for me to execute on it or actually build it. It's not going to come to fruition. And it needs to be viable. So this needs to be business okay. I mean, it's got to be either self-sustaining, it's got to be, it's got to meet some sort of internal hurdle that you might have, but it has to make business sense too, whatever that is defined at. But the problem is, and again, this is where I'll be critical of United in the past, is that you often start at the bottom too. We worry about, is it feasible and is it viable first? Where should you start? The top, right? Is it desirable? Does anyone care if this thing exists? Because if the answer is no, it doesn't matter if it's feasible, don't build it. And if it's not viable, again, it doesn't matter if it's not desirable. So part of human-centered design focuses you up on that desirable part to make sure that before, again, you have to answer all three of these. So I'm not dismissing the importance of all three, but don't start at the bottom. Start at the top. Okay? So, human-centered design boot camp in 5 minutes there. So now I want to talk about a specific project that we're working on that actually is still very young. We're still working on it, and part of my ask today would be if anyone's curious or interested in partnering with us on it, after the fact, we'd love to talk to you. But this comes from some work that we did last summer where we explored a domain to help care providers deliver the best care. That was the big problem that we set off to look into, how we might do that as a company. And a couple of insights that this idea was looking to solve was, one, we heard from care providers that when patients leave the office, they refer to it as the black hole. I have no visibility into what they're doing. They leave and they're gone. And where do most patients spend most of their time? Not in the office, but outside the office. We also learned from care providers that one of their biggest complaints is that patients don't do what they want them to do. Adherence to treatment plans is horrific. And I know I'm probably preaching to the choir here. But those two insights were kind of inspiration for this idea that we worked at, which was really in itself inspired by my daughter Grace and her math class. And the analogy here is that she came and asked me to do her homework, which by itself is very strange. But she came and asked me to do her homework on a Saturday, which is even stranger. And the reason why is that Friday, her math teacher had actually implemented a new game, right, that helps teach math. And when she does it right, she gets points, and she can customize her avatar with hair and sunglasses and sandals. And apparently she really likes to do that. So she loves math all of a sudden. And that's kind of where our idea came from is, and the other thing I should mention about Grace's math application is that there's a lot of data that's captured by that math application that then the teacher gets. And so now the teacher can see for Grace which math facts is she struggling with. And now she can customize her teaching to Grace. Instead of trying to teach everybody the same thing, she can see what Susie needs help with, she can see what Grace needs help with. And so this idea is really about how do we maybe help make care more fun, more exciting for patients by including game and game mechanics. So we're not looking to implement any new games, but bring them together. It's a very fragmented space that a lot of people don't know about, or they're very fragmented. So we're trying to bring those together in a more meaningful way so that, one, people actually are excited and encouraged to do the care plan, but also we can capture data then and then provide that back to their care provider as we can. And it turns out that Grace isn't alone in liking to play video games. I'm glad you're sitting down, but any guesses on how many hours a week are spent playing video games across the globe? In 1 week. Guess how many hours are spent playing video games? 3 billion hours in a week, right? So people obviously like to play games. I mean, I think a lot of the jury is out still on the effectiveness and health, but we think that there's something there that's worth exploring. And so what we did is, that's a big idea, a big concept, but where do you start to apply it? And what we started to lean into when we heard from providers was that asthma was certainly an area where, as a care provider, I would really like to know what's going on. My patients are either taking their inhalers too much, too little. It's a very complicated thing. It's life-changing for a lot of families. And so, you look at stats like 1 in 11 kids has asthma, and it's growing. You look at, it's the most common chronic condition in kids, and we spend $18 billion in treating asthma a year, including, the wasted time for parents missing work, missing school. So this was really inspirational for us. So one, care providers telling us that they'd really like to get more visibility, but it's a big problem. And so for human-centered design, first thing you do, what's the first step? You understand, right? So what do? We actually went out, we went out and talked to families with asthma, right? And we really looked at moderate to severe asthma. We didn't really feel like mild was a good place to start. And so we went out and interviewed about 17 families to learn about their experiences with asthma. What that was like. How did they learn about it? How did they cope with it? How has it impacted their family? How has their kid had to adapt? And so what you see here, I'm not going to read through this, but this is kind of an output of that empathy stage, right? So what needs do young families that have moderate to severe asthma have, right? And these were the 7 needs broken up between kind of mental resilience, so there's a lot of mental stuff that goes on with families, but also the emotional side of asthma. And I learned so much about asthma, but it is a big deal to families, and there's a lot of struggle, especially out of the gate. Once they get in the rhythm, I think it becomes more manageable, but the first 60 to 90 days, it's a big deal. It's life-changing, obviously. So, and just a couple examples of, this is what, this isn't everything that kids get, and there are some actually very interesting and engaging new concepts that are coming out in asthma, but what you see on the top are what is usually given out today, right? We've got, pictures of lungs and stuff like that. You've got scary pollen that you can color, and you've got the asthma action plan that's developed by the American Lung Association that parents take home and review with their kids. And then you think about, okay, as a kid, I can look at this stuff and engage with this stuff, or I can go do this stuff, which is what I'm used to doing, right? And I think it's very clear to us that there seems to be an opportunity to use games and game techniques to help, learn, or help kids learn about asthma, but also help to manage it, okay? So based on those needs and what we learned in kind of current state, we came up with a prototype. And so to my point about making very rough prototypes, on the table you'll see little cards, and we developed cartoons that displayed the experiences that could be delivered to families. And we went out back and talked with families, talked to moms and dads about, and you can see them giving us their feedback on, well, what did you like, what didn't you like? And that's part of it. The most important part is understanding why they like it or why they didn't like it, because that really helps you fine-tune your solution. So, very uncomfortable. We're just guessing here at this point. We think this is a good idea, but the concept really resonated very well. And this gave us an inspiration to come where we're at now, which is actually building a functional prototype. Again, not one that's heavily polished, but one that we're going to actually let kids use and work with clinical care providers to help customize and make sure that it's okay going out the door. So, again, wanted to share one example that's going on within United Health Group around kids. Lots to choose from. But one that I thought would be kind of a meaningful example of some work that we're doing. So if I were to leave you in summary with these 4 things, take these home. One is kids aren't little adults, so don't treat them as one and don't look at them as one. The second would be if you're going to design for kids, you better either have kids design for you, or you better really understand what they're about. The third thing here, I didn't hit a lot on this, but technology certainly is going to be a prominent solution in healthcare today. And I think Paul mentioned earlier that it's not everything, though. In fact, we have a program called Activate for Kids, which is a school program aimed at about 250,000 kids to help fight obesity and prevent obesity. And we've developed a technology called Dance Dance Revolution Classroom Edition. So if you've seen the malls where kids are up there doing the dance thing, we've developed a classroom edition where they do this for gym class, which they really like. We've deployed those, and those don't have nearly the effect of obesity and health and better eating when you wrap it around a really robust program. And so technology is great, but I would echo Paul's sentiments that it's not by itself, it's not the silver bullet. And then finally, if you don't use human-centered design, you don't know about human-centered design, I would really recommend using it as a way to develop more meaningful solutions. It definitely is something that will greatly increase the odds that your solutions will make that difference that we're all looking for. So thank you for your time. That's all I have, and then we'll wrap it up for questions.
Thanks, Ben.
Yep.
We're going to go till 7:30 here, but what I'd like to do is have Deb, and I guess it's just Deb's going to collect the cards and bring them back to me. And as she's doing that, I'm going to ask our panelists one question, and if you can all kind of answer this quickly, I'd appreciate it. So one of the things, as an old wizened hardball hospital administrator, I'm always looking after the money here. So maybe you can, and technology, by the way, I've discovered is kind of expensive. So maybe all of you can go around a little bit and just talk about your project and tell me a little quickly the business case for your project. So if you're coming to me as a hospital administrator and say, I need money to do this, what would you tell me? Now, think about also the environment when we're moving from a fee-for-service world into value-based purchasing and ACOs and all the other kind of stuff. So although United's not in that world, except maybe on the other side. But anyway, if you can just kind of make the business case, I'd like to hear about that. So maybe we can just start on the right here.
For us, it was really around safety and improving safety. And if you look at some of those earlier research studies and the cost of medication errors, it's sort of easy to justify adding technology that will improve medication safety based on the potential costs and risks to the organization of making medication errors.
Great.
So, Dan, ours is very similar. It's the value of care. So the value of care is the quality over the cost. So quality equaling outcome, safety, and service. And technology is there to help leverage what we can, all the clinical knowledge. It's definitely not the answer. However, if you don't see the system as a whole, you're never going to get back to what your investment really is paid for. So give us that $40 million capital equipment request and into technology. And I think that's what it comes down to. It's about the patients. If you can't invest in your patients, then you need to get out of healthcare, because that's what it should be about. You should try to make it centered, just like Ben was saying. You have to have the patients in the focus and be in the center of what you're trying to do.
I'll focus on the interactive patient care component, so our Get Well network and having that touch panel interface. I think if we step back and think just philosophically, moving into a focus of healthcare where it's really about people engaging in and owning in and controlling their health, how much do we do as an industry at empowering people to actually own their health, maintain, manage their care? And so the business case for interactive patient care technology and that kind of interactive potential at the bedside is really, we want to make sure by the time when patients arrive, that they're fully empowered with what to expect through their hospitalization. They know what steps are happening along the way and what they can do to be part of their health and well-being and move towards that discharge, so that they can understand those components and not just be sitting there like they've come up to a counter and they're waiting to be served. It's really their part of it. If they're not in that whole equation, then we're not going to have the same kind of long-term outcomes.
Yeah, and for ours, it's early, so our business model is still developing. I'd say there's probably two opportunities within that asthma opportunity. One would be obviously improved adherence, which is obviously going to reduce cost. ER visits would be another one, so asthma puts a lot of people in the ER. So if we're getting better compliance with the maintenance drugs versus the other stuff, and we've actually seen that with some of the hospitals we've talked with. A lot of pediatricians will send them to a centralized children's hospital because they're trying to reduce ER admits and readmits. They actually have staff that will go out and do home assessments, so there seems to be some business case there. I also think there's an opportunity direct to consumer for us on this one too. When we talk about apps, with games and stuff like that, people are used to paying 99 cents, $2 for an app, and so we're starting to lean into a little bit about people's willingness to pay for solutions like this. But not that that's the answer, but that's another avenue that would be something to consider given space that we're looking at for asthma.
Yeah, I echo a lot of what Susan said, and our medical director frames it up pretty well. And everybody's job in our organization is to serve the patient and for our patient population to put efforts forth to lead the biggest functional gains so that our kids coming through can have a productive and as near normal life as possible. So there's no doubt that the technologies that we've talked about are expensive. So we rely on the revenue that's generated as well as philanthropic support to try and put some of those pieces together to really create the best care environment that we possibly can.
Okay, we're moving on to kind of technical questions now. So for children's, how are the IV bags monitored so the correct bag is hung? Are they barcoded too?
They are. So the floor sack bags do have a manufacturer barcode on them, and so they should have an order in the system, and the order is compared against the barcode that is on the IV bag.
Here's one for Mayo. You are part of an integrated system. How do you handle the transition of teens, young adults, and child's onset of disabling conditions, CP, so forth, so on? So how do you manage the transition?
Yeah, so that's a great question. I think with a lot of kids, we see the complex care issues, so CPSB, and look to my colleagues because we actually develop multi-specialty clinics. And when I talk about multi-specialty clinics, it goes to the extreme. So basically, we have one-day clinics where it's a one-stop shop for our patients. So the patients come to the floor, and all the necessary providers come to them. So ortho, neuro, pulmonar, psych, dietetics, social services. And what we do is that during that time frame, you know, we have that management of the patients. They get all their visits, but also they're lucky because they work with their colleagues that also are taking care of the older patients. So your colleague that's taking care of the adult CP, and luckily these kids are living longer. I know Gillette knows too with those CPSP patients. I mean, it's hard to say it's time for you to find an adult care provider. We don't take care of 18-year-olds anymore. You can't do that. And so within our system, they have the adult colleagues right next to them, as well as be able to transition well. And CF is a great example too. When they do have that CF transition kind of moment, they do work with our adult specialty providers, and we're lucky also as well. I think most institutions we have double boarded, so med and peds boarded trained pulmonologists and infectious disease folks. And so that makes it easier for have those transitional kind of appointments and visits. So.
Great. Here's somebody who's quite charmed by implants, obviously, who said, how can I get admitted?
Oh.
So if you're 45 years old, can you still pretend you're a kid and get admitted?
Great idea.
We have
And
a
it-
robust volunteer program.
But here's a serious
screens.
question. Here's a serious question. Is there any correlation to better outcomes with this new environment?
I think that has yet to be discovered because you create an environment like that, and one of the things that we talk about at Amplats is that when we built the place and we walked into it, we had this question, did we build a masterpiece or did we just build a frame and a new canvas? And I think the way we're looking at it is we have a new canvas that provides us with a platform to begin exploring this. So it isn't the technology, it's like we've talked about already, it's the human interaction that's happening. So we have an opportunity now, having all these tools in place, to begin to do things with communication, with service recovery, with comfort, symptom management, creating a healthy or kind of a healing environment with sounds and sights and textures and things like that. So I think the jury's still out on that one. So I think also when you create an environment with this much technology, there's a lot of maintenance to do. There's a lot of learning for things break down. You realize that the $8 vinyl USB cord or HDMI cord that you bought instead of the $28 one that's
There's a reason, huh?
in time it's actually cheaper to buy the better one up front. But you figure these things out over time and you kind of grow into it. So we need to kind of get over that hump, and then also looking at moving from we use our co-design process in building this, but we're looking at an ongoing co-design process. So the design's not done. We can't have something with that's this complex without helping patients and families understand how to utilize it. But then also, I didn't talk about this, but our adopt room program, when rooms are adopted, it's a $200,000 gift. $100,000 goes into the build. The other $100,000 goes into an endowment that keeps that room up to date in perpetuity. So given that set of dollars or funding that's there, we can then keep building this into the future as we learn more through human-centered design practices, learning from kids and families what we need to do to make those improvements. We have some ability to approach that. So ask me again in a while.
So here's a question for United. Again, another kind of technical question. How do you select the families to interview and get feedback for prototyping? What's the criteria? Do you use incentives?
Yeah, so for ours, we were looking for families that were moderate to severe asthma. We looked for families that were recently diagnosed within the past 3 months. And of all things, we used Craigslist to recruit. Again, we're trying to really approach more of a lean mentality. You can do your focus groups; those cost you 10 to 12 grand at least. I was able to recruit 17 families. We paid them about, I'd say, $100 for an hour of their time. We usually gave them a $100 Amazon gift card, and I think again, 17 people, that's $1,700, right? So that's what we looked for our initial ethnography, and we just used Craigslist and compensated them $100 for an hour.
Okay, back to Sarah here. What impact on timing and nursing education did your new smart pump system have, and how did you overcome those obstacles? I guess that's it.
So our approach for nurse education throughout this project has really been at the bedside. So on each of our units, we've identified a small set of super users. They've had about a 1 to 2 hour class where they have had an opportunity to practice prior to our actual go live event. So they've been able to program the pump, see how it looks, see how it feels. And for all of our other staff nurses, they learned at the bedside on the day of go live. So they were partnered up with either a super user or one of our informatics team, And during their first couple of medication administrations, they had a partner with them. They could either choose to watch the first administration or have someone there supporting them. So we were really able to accomplish this without pulling all of our nursing staff into formalized education classes, which made it much simpler for us to roll out. From an ongoing perspective, it's been rolled into our ongoing nurse orientation process. So they will see it. They will not practice it during nurse orientation, but they will see it, and then it's part of the preceptor program when they get to the floor. So they will have someone assigned to them that will help them out during the initial usage.
Great. Back to Amplots. Who creates the educational videos for you? And are kids or adults featured? And the next question related to that is, do patients have access to the same videos after discharge?
So Kids Health is an organization, part of Nemours Health, that it's a company that's produced, I think, about 200 different videos that are put on Get Well Network. And they're all designed to feature real staff, real patients, real families in there. So if you're looking at an education video of something like a PICC line, you see a patient actually going through the process of preparation, learning about it, and having one and having it maintained and so forth, and having the bandages changed and everything. And they're all designed to be about 2 to 3 to 4 minutes, so that it's not too much information for someone that's in that kind of an acute stage of stress response. They can actually retain what's in there. And we also have the ability to upload our own video content. And one of the things, so that a lot of the imagery that you saw in the presentation was stuff that we're producing ourselves. We're buying a lot of the a Mac computer and a nice camera and so forth, and we're producing a lot of our own education on the fly, so we can not on the fly, I should say. We're empowering our frontline people who have the ideas and want to drive some innovation to grab the equipment and have some expertise in-house to help them and produce things on a short turnaround. Again, it's almost like the prototyping that was talked about. You try something small and easy, and if you really land on something, you can bolster it. So any kind of content we want to put in there. This platform does have a Get Well at Home feature that works through the portal. It embeds Get Well into like the Epic portal, MyChart, that kind of a thing. So you can access it, you can push out information, education, questionnaires, anything to families before they come in. And then of course they're using the system in the hospital, and then at discharge as well. After discharge, you continue to do that. And that's something that we'll be looking at in the future. And what was the last one?
Are they available from home? I think you can answer that.
Okay.
Yeah. Okay, this is actually from a question for the audience from United. Is there any organization open to partnering with United on future humor-centered design initiatives? I assume you can come up here to the front and talk to folks after that.
You're shameless, Patrick. You're shameless.
Yeah, Patrick.
Yeah.
Right. So we're about at the end of our time here. I just want to say this. Aren't you all proud to be part of Minnesota Healthcare? I mean, isn't this the best? When you hear these organizations, man, we are leaders in everything around the country here. And so you just saw 5 of those presentations. So anyway, this is wonderful. Thanks, everybody, for coming to St. Thomas. We'll have another event here in probably January. So anyway, thanks very much.